This poofy thing makes me nervous, like I have a big allergen right in front of me. Anyway, I'm Dr. Todd Finnerty. I'm a psychologist. I've been a psychologist since 2003, so going on almost 21 years. I'm dating this video, but as of 2024. And one thing I'm particularly interested in is sleep apnea cases where they're secondary to mental health issues, like for VA disability cases. And you may not know this, but if you're on YouTube and you're interested in VA disability claims, you probably know that there's proposed changes to the sleep apnea rating schedule, how they go about rating it, and one of the proposals is in relation to taking the CPAP, which is rated if a veteran has a CPAP, then they get a 50% rating, but so the proposals is to make that maybe not happen, right? And to the point where they might not get anything monetarily, right? So back when the proposals came out in fairly early 2022, I wrote up my public comments and submitted them to the VA. It's the sort of thing I like to do, apparently. And much like I did, if you saw my last video for the mental disorders rating schedule, this time it's not on my phone, it's on a piece of paper because my glasses just aren't that good, apparently. I'm going to read them to you. Yet another bedtime story. Kind of appropriate, I guess. So I'm going to cut off all the weird bells and music, though. I don't know. So it could end up getting long. So I wrote this on March 4th, 2022, and headed it with, the VA's proposed changes would incentivize failure and drive up associated healthcare costs and disease burden. Our veterans deserve better. It's a penny-wise but pound-foolish proposal. I disagree with the VA's proposed changes to how sleep apnea is rated for disability claims. Ironically, while the VA is concerned about saving the pennies they are spending on VA disability claims related to sleep apnea, the proposal is pound-foolish. While CPAP use, or breathing assistance device use, is not a foolproof proxy for impairment and loss of earnings potential, there are few other evidence-based contenders to replace it. Meaning, what the VA's proposed isn't really measuring impairment, to be honest with you, in a scientific way. More importantly, the unique position of CPAP use in the disability rating has created a positive public health phenomenon where veterans are now educating each other about sleep apnea and supporting each other's pursuit of the gold standard treatment of PAP therapy, CPAP, right? Or CPAP, that kind of thing. This has an incredibly powerful and positive public health impact, preventing all the negative consequences of untreated sleep apnea in veterans will save the VA money in the long term, despite the money spent on sleep apnea disability case claims. CPAP use has been proven to be cost-effective for healthcare systems. However, CPAP is also notoriously hard to adjust to, and a huge percentage of individuals prescribed with CPAP do not continue with CPAP use because of that. We also know that individuals with PTSD and other mental health conditions in particular have difficulties adjusting to PAP therapy due to their symptoms. The VA's new proposal would have a profoundly negative impact on veterans and reverse the course of progress that has been made in identifying veterans with untreated sleep apnea and increasing their adherence to PAP therapy. Sorry. I'm not too good at talking still, to be honest with you. The VA's ill-considered proposal would actually incentivize veterans to give up on an important treatment that is very difficult to adjust to, leading them to have an increased likelihood of countless other difficulties due to that untreated sleep apnea. This proposal would have a very negative impact on the overall health of veterans and quite literally kill them more by quickly contributing to their early deaths from the consequences of untreated sleep apnea. The public health benefit of using CPAP or breathing assistance device use as a proxy for impairment and potential income loss, including preventing the early deaths of our veterans, far outweigh any concerns related to the cost of paying for those sleep apnea claims, right? And then in the proposal, there's a notation as determined by a sleep study, right? They want to say whether CPAP is helping as determined by a sleep study. The as determined by a sleep study part fails to actually capture functional impairment, right? So I disagree with the use of as determined by a sleep study in the rating criteria. The notation as determined by a sleep study to decide whether treatment is effective isn't realistic, given that it isn't routine practice for veterans to keep getting sleep studies over and over again to see how their CPAP or other treatment is working. And the data from their CPAP rarely ever actually makes it into a medical record and can't reasonably be considered a sleep study anyway. The data the VA would want wouldn't be available to the veteran or the C&P examiner, and therefore there'd be an undue burden on the veteran, making it nearly impossible for them to prove their claim in most instances. In addition, it would create a push to keep providing sleep studies over and over again, which were not medically necessary, simply to help provide veterans with evidence for their disability claims. It would divert precious sleep study utilization to veterans seeking more data for their disability claims and worsen the backlog for veterans who need to be evaluated for sleep apnea for the first time. Regardless, sleep studies often do not yield the data that is most relevant to the continued impairment seen despite CPAP use. For example, the AHI, the apnea-hypopnea index, which is a measure obtained in a sleep study and is often used as a shorthand for severity of sleep apnea, is not an ideal predictor of actual functional impairment and has been much criticized in the medical literature. And here I bring up a study from 2020 where they offer a review on the data related to the AHI, the metric most likely to be looked at by inexperienced C&P examiners when addressing whether treatment was effective as determined by a sleep study. The AHI, as these authors in the study note, has been criticized for not capturing relevant clinical features of obstructive sleep apnea. The authors note the lack of evidence has become sufficiently robust to accept that clinically relevant sleep apnea cannot be ruled in or out based on the sole use of the AHI. In fact, the AHI fails to indicate a disease state or its severity in the individual sleep apnea patient. So sometimes you see someone might get an apnea-hypopnea index of like 4 one time, and it doesn't make that 5 cutoff score, and then they get another try and it's like 20, right? So it's, it can be heavily dependent on the night sometimes too. This conclusion is supported not only by the various trials showing a flimsy correlation of the AHI with symptom scores and associated comorbid conditions, but also because the AHI has been found to explain no more than 25% of the variance in relevant outcomes such as driving performance and sleepiness. So people can have a lot of difficulties and it doesn't necessarily match with what their AHI is, the apnea-hypopnea index, right? The authors note the widely accepted severity cutoffs of 5, 15, and 30 per hour to say mild, moderate, severe, right? Introduced in the Chicago criteria are invalid. It has been emphasized over and over again that these severity categories are arbitrary and misleading for clinical decision making. Ergo, AHI should be abandoned as a standalone exposure variable of clinically relevant sleep disorder breathing in the individual sleep apnea patient. The authors note that this is actually bad news for all the organizations that rely on AHI cutoffs for decision making, such as the VA would be trying to do if they were saying, oh, you had a sleep study and it was bad, and then you had a CPAP titration study afterwards and your AHI was lower, right? So CPAP means you don't have sleep apnea because of this AHI cutoff score, right? Not a good plan. Given that the field is moving away from using sleep study measures like the AHI as a proxy for impairment, the VA should not burden veterans with this non-evidence-based proposed impairment rating system. Even if a follow-up sleep study was done related to the impact of treatment on the AHI, despite a lack of sufficient ties to actual functional impairment from this measure, this is just a limited snapshot in time. The measure can vary significantly based on a variety of factors. It also does not consider the fact that sometimes individuals undergoing a sleep study have difficulty sleeping. This difficulty sleeping means an increased probability that their events won't be sufficiently captured in the study, or the metrics obtained were not reflective of a typical night. Therefore, issues like insomnia and PTSD leading to them failing to sleep sufficiently during the study could potentially lead to metrics on the study which would imply that their treatment for sleep apnea was actually working well when it wasn't. Metrics like the AHI could therefore be deceptive in settings where an individual with PTSD or insomnia was not able to sleep, because the veteran had not entered the sleep state long enough to have sufficient apnea or hypopnea events recorded. I mean, we've seen it plenty of times where, someone with a mental health issue and trouble sleeping tries to do a sleep study. Maybe they get 2-3 hours of sleep, and it's like, oh, hey, the sleep study shows that your apnea hypopnea index wasn't high enough. You don't have sleep apnea, and really they just didn't sleep enough to show it. They didn't sleep enough to show it, right? Because of comorbid issues, like some of those mental health difficulties they had. Sleep studies also have no measures of the many actual lingering functional impairments tied to sleep apnea, such as cognitive impairment. The VA suggested treatment being ineffective was as determined by a sleep study, but I don't see where the VA is indicating that they are willing to consider the results of neuropsychological examinations or pay for a neuropsychological evaluation for every single veteran having continued lingering cognitive symptoms despite their CPAP use. And presumably the VA wouldn't want to keep sending them to the sleep studies for disability purposes either. Given the increasing use of auto CPAP, it is becoming less and less common for individuals to even have an attended CPAP titration study, let alone additional full sleep studies to evaluate their treatment effectiveness. So the data related to ongoing impairment is not likely to be available in veterans' medical records. So it's like, especially when in the pandemic, like sometimes you have the first sleep study, probably a home sleep apnea test really now, and then maybe there might be a second one where they see, well, what pressure is your CPAP going to be at? It's much less common for that to even happen, especially now when the ranges can be set remotely, can be set with your auto CPAP can see, oh geez, how are you doing, and it responds to you. So that second sleep study might not even be there to see how you're doing on the treatment, right? So the as determined by sleep study, it may not even be in there. That second one might not even be in the file, right? Because there might not have been one. Sleep apnea leads to functional impairment, and CPAP can help with this functional impairment. However, it's a misconception that CPAP therapy is expected to resolve all impairments for an individual with sleep apnea. This is not consistent with the scientific evidence. In addition, as noted, the AHA is not a reliable measure for all the functional impairment associated with sleep apnea. So in this, I go on with like 2 more pages of research studies. I'm not going to read it all because I might have just cured your insomnia already. Sorry, but I am going to hit a couple that are in here, and I'll link to it in the thing if you want. It's been on my website for 2 years. I don't think too many people read it, so here I am subjecting you with it anyway. But people keep asking me about it, so it's like, here you go. If you don't want to read it, I'll read it to you. How about that? So I highlighted a few sentences and these are most of what I'm about to read are quotes from research studies. We know that cognitive impairments are commonly seen in patients with a sleep apnea diagnosis, right? Several studies have shown that sleep apnea has an adverse effect on inductive and deductive reasoning, attention, vigilance, learning, and memory. So there's this one study where 110 patients with sleep apnea were on CPAP for 3 months. And then they were compared to normal people. Sorry to say normal people. It will simplify. People without sleep apnea who weren't using CPAP. Compared to the community sample, participants with sleep apnea were significantly sleepier, had impaired mood and quality of life, and showed decrements in neuropsychological functioning, specifically psychomotor function, working memory, and vigilance, right? That was with CPAP use for 3 months, right? So these significant decrements persisted in most outcomes even in those persistent participants with adequate device usage. So people who were compliant with their CPAP, adherent with their CPAP, sorry, you're not supposed to say compliant anymore apparently, but the people who are using it appropriately still had all these problems, right? So these findings suggest there may be neurological changes related to sleep apnea that do not respond to CPAP treatment, right? There's other studies that say sleep apnea associated with high risk of cognitive impairment, including Alzheimer's disease, and CPAP only offers partial improvement in the cognitive problems caused by sleep apnea, right? Another one says there's growing literature. Multiple studies indicate individuals with sleep apnea show impairments in attention, memory, and executive functioning. And while CPAP was the most effective and widely used treatment for sleep apnea, the studies of CPAP use showed that, in general, no consistent effect of CPAP use on cognitive performance was evident. So these several studies have reported that CPAP treatment has no effect on cognitive performance. And these cognitive difficulties have long been observed in sleep apnea patients. And although CPAP is a well-established effective treatment for sleep apnea, it does not definitively reduce the host of cognitive deficits observed among sleep apnea patients. So, I mean, here I am, a psychologist. We're talking about cognitive deficits. That's not something a pulmonologist would usually talk about, right? But whatever, The evidence reflects significant functional deficits may persist despite CPAP treatment. The evidence also reflects that a sleep study, including the AHI result, does not reliably measure these deficits. A sleep study will not reliably predict the impact on a veteran's earnings power or the extent to which CPAP has made them whole in relation to the impact on their relationships, community functioning, and increased likelihood of serious complications such as heart attack, glaucoma, diabetes, cancer, and cognitive behavioral disorders. So let's sum this up. We should stay the course on identifying and treating sleep apnea in the veteran population. The VA should do nothing and make no changes to the current disability rating structure for disability related to sleep apnea. There are no evidence-based alternatives, and the current proposal will actually harm the overall health of the veteran population. By making no changes on this proposal, the VA will save the time, confusion, and money they would have spent proliferating new DBQs, training raters, training CMP examiners, and confronting the chaos caused by having two different rating approaches to deal with on sleep apnea. Of course, veterans who had a CMP based on an old DBQ couldn't possibly be rated fairly in the new system, right? The VA will also reap the benefits of the extensive cost savings on the healthcare side, as treating sleep apnea appropriately prevents much costlier healthcare difficulties. Last page. Down the road. We'll reap the cost-effective, significant public health benefits of having an informed population of veterans who are motivated to educate each other about sleep apnea and motivated to encourage each other to stick with their PAP therapy. The VA's current disability rating structure for sleep apnea should continue, as there is nothing evidence-based to replace it with, and it also serves as a cost-effective public health campaign promoting the identification of sleep apnea and adherence to gold standard treatment with PAP therapy. The VA's proposed changes would incentivize failure and drive up associated healthcare costs and disease burden. Our veterans deserve better. Thanks. I'm always happy to answer questions. Whatever you're supposed to say here again, liking and commenting and subscribing. Thanks again. And Hey, you made it to the end of the video. Thank you. Here's the part where I'm supposed to beg you to click the like button, subscribe to the channel, and perhaps post a comment. But also, you can subscribe to my free email newsletter where I talk about my practice and my thoughts on things related to VA disability claims. You can subscribe to that on my website, nexusletters.com. And if a Nexus letter from a psychologist is something you or someone you know needs, you can get one from me at nexusletters.com. Thanks again.